All right. So the next presenter that we have is Dr. Chmielewski. He's a board certified in internal medicine and hospice and palliative medicine. He completed his residency in internal medicine at NYU Medical Center, Bellevue Hospital Center, and then completed his fellowship in hospice and palliative medicine at New York Presbyterian Hospital or Columbia University Medical Center. Dr. Chmielewski has lectured in New York City as well as the local, state, and national levels on his areas of professional expertise and interest, which include the management of pain and other physical symptoms, the medical management of emotional and psychosocial symptoms in the seriously ill, provider patient family communication, biomedical ethics, and end of life care. Thank you so much for joining us.
Hi, thanks for having me. So I want to spend the next 45 minutes telling you all about hospice. And I've entitled this talk, Hospice, There's Always Something We Can Do. Now, hospice is full of all these wonderful little aphorisms, like there's hope in hospice because there's HOPE. And that's cute and kind of saccharine, but I actually really like there's always something we can do, because you'll still hear all the time in medical settings of patient and family being told there's nothing more we can do. And while there may be nothing more that we can do for the spreading cancer or the failing heart or the obstructed lung, there's always something that we can do for the patient who has that cancer, that lung, that heart, and for their family. And so that's where hospice comes in. So I have decorated this decorated this presentation with images from across art history that mainly depict death and dying and suffering, and especially around the end of life. So kind of like a counterpoint to all the ways that death and dying has been experienced without the benefit of the support of hospice. And this is my favorite image from all of art history. This is the death of Socrates. And Socrates here has been condemned to die for the teaching of heresy. And here he is reaching for the cup of hemlock, the poison that will end his life. And yet he is teaching right up until the very last moment. And I've always kind of wondered what's being said in this scene. And I think that if this were unfolding in a modern context, it'd be pretty clear that somebody would be asking for the code cart to be called in. And I make this little dad joke to remind us all that death is a natural and normal part of life. It is going to happen to all of us. And at a certain point in time, for our patients who are seriously ill, it becomes a question not of if and not of when, but of how, and what that dying process is going to look like. So it's not a failure of the system, it is part of the human machine. So I don't have anything to disclose. I am the full-time medical director here at United Hospice, which is a not-for-profit, community-based, mission-driven hospice, and I don't have any outside financial entanglements. And my hope for you all today is that you'll be able to advocate for hospice-eligible patients by sharing information about the hospice benefit, that you'll be able to talk about how palliative is used in hospice and palliative care versus how it's defined outside of hospice and palliative care, which is kind of opposite in some ways. We'll talk about that. And I'm going to talk about some recent changes, some ongoing challenges, and some barriers to hospice enrollment. So hopefully that every patient who is eligible to receive hospice services can be referred and receive those services appropriately. So I have framed this presentation as a question and answer, where I will be providing both the questions and the answers. But if you have additional questions, please send them to the moderator or email me, and I'll be happy to address anything that I can that I have time to address. So first, what is hospice? Hospice is specialized care for patients and families who are confronting serious life-limiting illness. It's defined by a Medicare benefit that was established in the early mid-1980s, and then all the state Medicaids and most private insurers have sort of mimicked the Medicare benefit and created their own their own version of the hospice benefit. And it basically establishes a system for providing comprehensive palliative care where a patient resides. So it's a benefit that is very well suited to providing care in a home-based setting, in assisted living, in a long-term care facility, not very well geared towards care in the hospital, which is its own challenge. We'll talk about that a little bit more later. But the hospice provides this comprehensive palliative care approach. Who's eligible for the hospice benefit? Well, there are two criteria. First, you have to be eligible for Medicare Part A, or have other insurance that has a hospice benefit, or be willing to accept charity. Now, my hospice does not turn anybody away from our home-based program for the inability to pay. We treat the undocumented the same as the insured. So that's not really much of my criterion, because that basically covers just about everyone. So the real criterion then is that the patient must have a life expectancy of 6 months or less if the terminal illness runs its normal expected course. And that's it. Those are the only criteria. Anybody who fits these criteria, or any patient who fits these criteria, is eligible for hospice. Note that a patient does not have to have a DNR order in order to receive hospice services. Although I will note that a DNR order is almost certainly appropriate for anybody who's in the last days, weeks, months of life, because at that time, with that prognosis, those interventions will harm them and not help them, and so it should not be done. What does hospice provide? A whole lot of things. Hospice is an interdisciplinary model of care, so that includes providing in-home nursing visits, social work visits, spiritual care services, some amount of aid services, not enough to provide all of the custodial care that a patient needs, but enough to support family, friends, hired caregivers in providing that care for the seriously ill patient in the patient's home. Hospice also provides a volunteer program to do anything from sitting with a patient so that the family can go run errands, or providing other kinds of support to patients and families, to playing cards with a patient. We have a patient who's we have a volunteer who is a veteran, and so talking to the veteran patients, we have a common thing that they can discuss and do life review. Hospice also provides 13 months of bereavement counseling after the death of the patient, so the services continue even after the death of the patient. Hospice also provides dietary counseling, some complementary therapists, including massage therapy, music therapy, and oversight by a hospice physician, me. And I'll add that, as if that wasn't enough of this already wordy, busy slide, there's a whole nother side of this slide with other great things that hospice provides. Hospice provides all medications and all durable medical equipment related to the terminal illness and all related conditions. Now, this is an interesting turn of phrase, terminal illness and related conditions. So it used to be in the old days that hospice was responsible for a terminal diagnosis. So if somebody was on hospice for, say, lung cancer, but they also had, say, end-stage renal disease requiring dialysis, hospice could say that they're getting hospice for lung cancer and the dialysis is still Medicare's job. Medicare has now made clear that hospice is responsible for, quote, virtually all care that hospice beneficiary requires. So we can't exclude things anymore if they are, that are related to patient's symptoms or the patient's serious illness, the patient's dying process. So basically, this terminal illness related conditions means everything. Maybe the most important thing that hospice provides is 24/7 on-call support, including nursing visits, because just about everybody who is seriously ill will at some point have a problem at 2 a.m. And if that patient is not on hospice, then they'll call up their doctor, and whichever one of that doctor's 50 partners happens to be covering that night will answer and eventually call them back and listen to the story and end up saying, I don't know your case very well, you should go to the emergency room. And that may be the appropriate thing to do for 98% of people who have serious medical issues. But for patients in the last days, weeks, months of life, often these patients are not best served by being in a hospital, and are best served by being at home with intensive support. And so when this patient that I was describing is on hospice and at 2 a.m. has a problem, they will call up the hospice nurse will answer and say, do this while I'm on my way. And we are very successful at preventing patients from needing to go back to the hospital for interventions, workup that may not be goal concordant and may not actually be more beneficial than burdensome. In hospice, we think about the patient and the family together as the unit of care. This is kind of analogous to pediatrics. I mean, before COVID, my wife and I used to take my kids in for checkups or whatever, and the doctor spent more of his time treating my wife and myself than my actual kids, who are pretty healthy. But we think of it in a very way that's very much analogous to pediatrics, that even though the patient is ostensibly the target of care, it's really the patient's entire milieu that is taken into account. And in hospice, we have all this expertise that we want to share, expertise about all the different aspects of the dying process, the physical, the psychosocial, the spiritual aspects of the dying process. And we can do a lot of anticipatory teaching, a lot of caregiver training. See, we are training families to support their loved one at home through the dying process. There's limits as to how much we can do. We can't move in, we can't set up an ICU in the home, but there's a lot that we can do to train and prepare families to know what to do and to call us for assistance when they need it. Hospice also provides respite care. If the family has caregiver breakdown or needs to go out of town for a family event or something, then the care can be arranged for the patient at a facility for a short period of time. And hospice also provides some limited amount of inpatient care for patients who have symptom management needs that cannot be met in any other setting, can be then met in an inpatient setting like a hospital or a hospice inpatient unit for a short-term time while those needs are then addressed to the point that they can be addressed without the need of that kind of a setting. So that's a lot of great things on a very busy, wordy slide. That may lead to the question, why doesn't everyone get hospice services? Well, interestingly, prognosis is not usually the limiting factor. I personally probably review about 2,000 charts a year, and on almost all those charts, I say this patient appears eligible, this patient is definitely eligible. Most of the time I say, not only is the patient eligible, I wish that they had called us a couple of months ago when they were eligible and we could have given them more services and more benefit from hospice. But it's unusual that I say, yeah, I think that this patient is not hospice eligible. And for patients like that, we do have at my hospice, we have an outpatient home-based palliative care program that can step in. It's certainly not as intense as the services that hospice provides, but it's at least some way that we can support people in our community. So if it's not prognosis as a limiting factor, since almost all of our referrals are hospice eligible, the limiting factors are the fact that, for one, hospice needs to be invited. There are all these eligible patients out there, and we're over here, and somebody needs to connect the two of us. And that can be, in the medical profession, that can be neighbors, that can be clergy, but somebody needs to hook us up. And then once we're hooked up, the patient or their surrogate needs to decide to elect the hospice benefit, which comes with some trade-offs. And complicating both of these two things is the fact that there's a lot of misinformation that complicates these decisions for patients, families, and for providers. And I apologize if the slide is grisly, but this is kind of what a lot of providers and a lot of civilians think that hospice does to patients. But it is actually completely incorrect. It's been well studied and now shown that hospice not only improves morbidity and symptoms, which is of course the point, but also hospice improves mortality. And some of it makes sense, if you devote yourselves to the whole patient and to making sure that their experience is as good as possible and their symptoms and their distress are all managed as best as possible, it makes sense that their body's resources would then allow them to continue interacting with their life and living for longer. At least it makes sense to me. So why doesn't hospice get invited? Well, providers tend to really struggle with prognostication. So, and when I think about prognostication, we consider certain things like functional status, the trajectory of disease. Look, if somebody has been hospitalized 3 times in the last 3 months, if they're discharged home again, there's a very good chance that if they survive long enough to make it back to next month, they'll be back in the hospital again. And our system affords people the right to choose that kind of a plan of care. That's not what most people would choose when really given the choice. Most people would not choose that sort of gerbils wheel of medical intervention and more, that back and forth between the nursing home and the hospital. Most people would choose for a different plan of care, a different set of priorities if they realized that were an option. Also want to consider the natural history of disease. There are some illnesses that just portend a particularly grim prognosis. Pancreatic cancer, glioblastoma, small cell lung cancer. These patients are going to be have a very limited prognosis, regardless of what treatments they are pursuing. So think of a prognosis as a range. This is the big hint here. Patients will say to me all the time, "Well, the doctor said I had 6 weeks," or what have you. Now, this can actually be very, very damaging to patients. So often when doctors are asked about prognosis, the first thing they'll try to do is run the other way, because most doctors don't want to get into that kind of a conversation. And I can understand that. It's uncomfortable. There's so much that we don't know. And we, I think, as a profession, often don't do well with the unknown. But I encourage you to give prognosis as a range, because that patient for whom the doctor said 6 weeks, well, what if the patient lives for 2 months or 3 months? The expected prognosis was only 6 weeks. The family came, the family rallied, the family departed. There's an odd sense of letdown or a sense of betrayal almost when patients outlive their prognosis in that context. And of course, even worse is if the patient was told 6 weeks and then dies after 2 weeks. And then everybody feels like they didn't have the adequate time, and they almost feel lied to about the amount of preparation that both emotionally and logistically into to deal with the dying. So prognosis as a range would be the ranges of hours to days, days to weeks, weeks to months, or months to a year. And that is usually specific enough to allow patients and families to wrap their arms around it and sort of understand what they're dealing with, and yet broad enough to acknowledge the fact that there's just so much that we don't and cannot know about the timing of death. In talking to non-palliative care clinicians, I like the surprise question quite a bit. Would you be surprised if this patient were to die in the next year? And if you would not be surprised the patient were to die in the next year, that patient very well may be hospice eligible. If that patient is hospice eligible, they may desire the kind of plan of care that hospice can provide. Why do I say if the patient dies in the next year when hospice benefit says 6 months? Well, providers tend to overestimate prognosis by a factor of 3. And when the provider knows the patient really well and they have a long history, it gets worse. It's a factor of 5. Because we physicians, believe it or not, are human beings and we have our own biases, and that influences the way that we think about our patients and their care. So the surprise question can be very helpful. Eligibility criteria. So when I was in training, I remember hospices used to come into the hospital and like hand out little booklets with all their criteria. It would look something like this. Now, obviously, I put this up as a joke. You're not supposed to read or remember any of this stuff. The point is that I don't think eligibility criteria is that helpful. I don't think the eligibility criteria are that helpful because, do you need all of these? Do you need one of these? Is this a suggestion? Is this absolute? It's very hard to interpret. So instead, there's a few things that we can boil down a bit. Really, few things. For instance, cancer. If somebody has metastatic solid cancer, they're almost certainly going to be hospice eligible. If somebody has cardiac disease that is so severe that they are symptomatic at rest, either with dyspnea or angina, that patient is almost certainly going to be hospice eligible. If the regulatory language around pulmonary disease is room air hypoxia and confined to a bed-to-chair existence due to their lung disease. So that's pretty broad. But these patients are, again, in the eyes of Medicare, more likely than not to die in the next 6 months and therefore eligible for hospice. Dementia here, the short version is can't talk, can't walk, had a complication. So all these patients who are bedbound and nonverbal, who get brought in from nursing homes to the hospital and often back and forth, many of them, most of them are very likely to be in the last 6 months of life and may be eligible for hospice services, which they may desire if that is offered to them. So why doesn't hospice get elected with all of these great things I've been talking about hospice doing? So one of the problems is that electing the hospice benefit requires the patient to forego their regular insurance coverage for all care that's related to the terminal prognosis. Now that care doesn't go away, it's just that it then has to be coordinated by the hospice and it's supposed to be palliative in intent. But what it really comes down to is that the patients have to forego a little to gain a lot. And the things that patients forego, for instance, in hospice, there's no rules absolute about what we do and don't do. I'll talk a little bit about how we make some of those decisions. But for instance, it's unlikely in hospice that we're going to be doing, ongoing scans, ongoing lab work, because the reason to do scans and lab work is if the result of that will lead to a change in management, which has already been determined is not going to be, is not going to be something that is meaningful to that patient's medical care. So it's unlikely that we're going to be doing those things. But those things at this time, in the last days, weeks, months of life, are of low value and diminishing value. Whereas the things that they stand to gain, like they've never had somebody that they could call at 2 a.m. before, but now they have it. And they may not realize that they need that now or will need that very soon. That's of high and increasing value compared to the things that patients tend to forego when they elect the hospice benefit. So what then does, if all the care is supposed to be palliative in intent, what does that really mean? Well, in hospice, we think about palliative as meaning symptom-directed rather than disease-directed care. We think about it as being comfort-enhancing rather than life-prolonging. Though I will note that in patients in the last days, weeks, months of life, enhancing comfort is often the best way to prolong life. We try to minimize invasiveness and the medicalization. We try to look at the whole patient and remove things that are not clearly benefiting the patient. So we try to look at the broader picture. That's sort of our bias is to look at the broader picture. So there's the classic example of it's almost a cliche of the oncologist who treats the cancer but forgets the patient who has the cancer, and hopefully that's a thing of the past. But that is when I was in training, I went to see a patient who was clearly dying. And I was on and off of dialysis. And while I was starting to have a family meeting with the family at the bedside in the SICU, the attending nephrologist walked in and said, "The creatinine is much better today." He wasn't wrong. The patient didn't need to go to dialysis that day. But a family in that situation hears the patient is much better today. And that patient, of course, died a few days later. So we just have to be thoughtful about what our biases are. And moving into a broader focus is sort of the way that we approach things in hospice and palliative medicine. I get the question, why can't hospice patients get this or that or the other thing? But as I was saying, there's no real rules to say what we must or must not do. There's nothing that we don't do by a matter of practice. Every case is decided individually. The thing that we're going to think about, of course, there are some philosophical issues. That doesn't really interest me that much. And there's some people who think, well, a hospice patient shouldn't get this, that, or the other thing. That doesn't really interest me. There are some practical pressures. Anything that hospice provides has to basically come out of the pocket of hospice. We have to, we can't bill for any of the services that we provide. I'll explain the finances of hospice in just a minute. But even that is far less important than the question of what is the balance, what is the benefit, and what is the burden. This balance between benefit and burden changes as somebody gets closer to the end of life, and things that were previously beneficial become increasingly burdensome. Somebody will say, well, I've been on that med for 20 years. Well, it did its job. It got you to this point, but things are different in your body now. And so our approach needs to be different. And some of the things that are just done as a matter of routine, somebody goes to the hospital and they may be a little bit dehydrated. They get pumped up with fluids. That may be the right thing to do for 98% of patients, but for the 2% that are in the last days, weeks, months of life, that can often be counterproductive and it can end up causing symptoms and even shortening life. So we just have to, think about anything that we do reflexively as we think about what is the most appropriate care for patients, especially in the last days, weeks, months of life. So I mentioned the practical pressures and the finances of hospice. The way it works is that hospice is paid a small daily rate out of which we have to provide all of the services that we've discussed. It's about $200 a day. And from that comes my salary and the salary of all of our nurses and social workers and chaplains and so forth, and aides and so forth, as well as all the medications, all the durable medical equipment. And so for ethical nonprofit hospices, margins are very low. And so we can't bill for any individual services. And so we need to think about cost effectiveness when we think about what is reasonable and necessary for management. But benefit burden ratio is always going to be the most important thing. And we will find ways to provide even expensive interventions if they are actually medically appropriate. And they are palliative. They are the best appropriate palliation for a certain condition. So what is reasonable and necessary? Well, different hospitals may decide differently, but some things that we think about are, again, as I was mentioning before, labs or radiology. The point of this is if this is going to change, the reason to get a lab or a study is if it's going to change management. And usually that's not going to be the case in somebody in the last days, weeks, months of life who's receiving hospice services. Transfusions, I find that patients are usually transfused to a number rather than to symptoms, and that transfusions can be quite burdensome and both in terms of the fluid load and in terms of just the whole process, and that there are usually better ways than transfusions to address any symptoms that would be associated with anemia. Specific medications, again, we try to encourage deprescribing of medications that are no longer clearly beneficial and substitution of more cost-effective alternatives for medications that may still be beneficial, but are not the most cost-effective options. So we try to deprescribe, we try to recommend formulary alternatives, and the question of chemo and radiation comes up. It's not impossible, but because of logistics and cost, it's usually something that will happen before somebody comes to hospice. And inotropes, well, I used to have a very open policy about inotropes until we got very badly burned one time. It's just, again, these things are taken on an individual basis. They're very costly. They're hard for hospices, especially small and medium-sized hospices, to bear the cost of. And we want to just make sure that we are using our scarce resources to make sure that we are doing things that are the best for the most patients. Okay, sections 2 and 3 of this talk are much shorter than that section, but let me get on into talking about some hospice odds and ends. So just little nuances about the hospice benefit. There's still this thought that hospice is for cancer patients and cancer patients alone. Although nationally, cancer patients are less than a third of all hospice patients now, a little bit more than a third locally at my organization. But the point is that the majority of patients receiving hospice services are now no longer cancer patients. Where is hospice? So hospice is an idea. It's not a place. It is a model of care, and services through the hospice model can be provided wherever a patient resides, which includes private residence, a skilled nursing facility, an assisted living facility, and I wanted to mention in here the hospice residence and the hospice inpatient unit. So we have at my organization the Joe Rasso Hospice Residence, which has both of these programs under one roof. The hospice residence is kind of like a hospice nursing home. So patients get normal home hospice care, but not at their home, rather in a sense at our home. So it becomes sort of like a long-term care, even though care is not very long-term usually on hospice, a long-term care model of care for hospice patients. And then there is the hospice inpatient unit, and this is where patients receive general inpatient level of care, meaning the kind of care that they would get in the hospital. This is for patients who have acute symptom management needs that can't be managed without, say, multiple IV push medications, that we will use these medications or we'll do whatever is necessary to with hospital level techniques to make sure that those symptoms get controlled, that they can then be bridged off of those hospital level interventions and back to home or wherever they reside. And I would mention that the hospice inpatient unit is something that's completely covered by the hospice benefit, but the hospice residence is probably the only thing in our program that is not covered entirely by insurance and philanthropy. For the hospice residence, Medicaid covers room and board there. Medicare does not. And so patients with only Medicare or private insurance have to pay privately to pay room and board for a hospice residence. Right. So other little things about the hospice benefit you should know, there are these 4 levels of care that all hospices are required to provide. Routine home care is sort of what most hospice patients are receiving, including patients at our hospice residents mostly are receiving routine home care, even though it's technically, again, our home. That's like normal hospice care. Then there's continuous home care, which is ill-named. It should be called crisis care because it's not necessarily continuous, but it is, again, for crisis. It allows a hospice to put nursing in the home for at least 4 to 8 hours a day, between midnight to midnight, and to provide really to basically provide the kind of care that is needed to prevent somebody from having to go to the hospital, to provide the support and skilled care that would otherwise require the patient to call 911 and go back to the hospital. Then there's inpatient respite care. As I mentioned earlier, this is for patients whose families need a break for whatever reason. They're going out of town or there's caregiver breakdown. And this can be for up to 5 days at a time at a contracted facility. And then there's general inpatient level of care, the hospital level care, most of which we provide at our hospice residence on our inpatient program, because these standards for billing at general inpatient level of care are very, very high, even higher than just being in the hospital. There has to be uncontrolled symptoms that need hospital level interventions to control. So it can be a very dicey issue to have hospice patients getting services in the hospital, because there's pressure on the hospital to get patients on hospice. There's pressure on hospices to not have patients on GIP unless they truly, truly deserve it, which is the single biggest of regulatory scrutiny for hospices. So other more hospice benefit, more aspects of the hospice benefit here. Benefit periods. Patient can receive hospice services as long as the patient remains eligible, meaning as long as the patient is thought to be in the last 6 months of life or less. And there are these benefit periods, first 2 90-day periods, and then an infinite number of 60-day periods. From the 3rd onward, the payer requires that the patient be seen for a non-billable administrative visit by a doctor or a nurse practitioner. But again, they instituted this thinking that they would reduce hospice long stays, but actually had the opposite effect, because the nurse practitioner going in only every 60 days is going to often pick up on things that the nurse going every week maybe has just become sort of accustomed to. And so we can see the change a little bit more clearly with the face-to-face evaluations being done. So there's only 5 ways that hospice services stop. The most common way is death, but then even after death, services continue for 13 months for the survivors on the bereavement program. Then there's the way of that hospice services can stop that is patient or surrogate centric. At any time, the patient or surrogate can say, no, I don't want this hospice stuff anymore. I want to go back to my regular insurance. Hospice, you're fired. That's called revoking the hospice benefit. And that's totally fine. But what they can't do is bounce back and forth, because that's Medicare fraud. And it makes it look like we're committing Medicare fraud when it's really a patient or surrogate committing Medicare fraud. And I'll tell you, there's a lot of malfeasance in the hospice industry. There are hospices that'll say, oh, you want one more PET scan? Okay, so you revoke hospice today, and you'll go tomorrow to get your PET scan so that Medicare will pay for it, and then we'll sign you back onto hospice the day after that. That's fraud, and we would not do anything like that. But because there's so much fraud, we have to avoid even the appearance of impropriety. Then there are the three ways that hospice can stop services unilaterally. If a patient leaves our service area to the point that we're not able to reach them to render the required care, then we're required to discharge them. If the patient is no longer thought to be in the last 6 months of life, which can be a difficult call to make, one of the hardest decisions I have to make is to decide that patient is no longer eligible for our services. Maybe they're no longer eligible, maybe their prognosis has been prolonged because of the intensive services that they're getting from hospice. But nonetheless, if prognosis is thought to be over 6 months, the patient must be discharged from hospice. And the last is discharge for cause. That's, if a patient if caring for the patient is unsafe to basically like the hospice staff. Now, patients can be unsafe to themselves, but it's very, very rare that there's discharge for cause. Last and the shortest section, some other ongoing issues I want to share with you about hospice and the hospice benefit. So what else should you know? So when hospice started in the early mid-1980s and before there was a hospice benefit, there was a bunch of companies like ours, small, community-based, mission-driven nonprofits. But now, almost just about 75% of hospice services are provided by for-profit entities in this country. And it's not to say that for-profit is inherently evil and not-for-profit is inherently virtuous, but it seems to break down that way quite a bit in this particular industry. For-profit hospices have much longer lengths of stay, meaning that they probably admit patients maybe before they are truly eligible for hospice, and they may keep certifying them even though their patients may not actually be in the last 6 months of life. There's a real cherry picking of cases. There's a whole bunch of things that go on that are problematic. Luckily, in New York State, we only have 2 for-profit hospices, and they are both pretty ethical practitioners, as far as I know. So, but and in New York, we also have certificate of need, meaning not anybody can just open up a hospice. There are only a certain number of hospices allowed per area. This is good because, for one, if we had, say 10 hospices in my area, the talent would be completely diluted. It'd be very hard to recruit and maintain top-notch staff. But also, just even down in New Jersey, there could be 50 hospices that serve a certain area, and it's just it just makes it rife for fraud. So there's other things to know. There's this U-shaped reimbursement model because to try to cut down on these long stays and inappropriately long stays, where Medicare pays a little bit more at the very beginning of care and a little bit more at the very end of care, with a dip in the middle. Because length of stay is so short, as I'm going to talk about in a minute, most of our patients are often at the very beginning or very end of care, but they're trying to do things to combat the fraud and malfeasance that's going on in the industry. I also want to mention that it used to be that patients had to have a clear diagnosis, and if they didn't, they'd be put on hospice for debility or failure to thrive. Then Medicare said, no, you can't use those diagnoses anymore. It doesn't change who's eligible for hospice. The criterion is this patient in the last 6 months of life? It doesn't change no matter what the diagnosis is. If you think that the patient is in the last 6 months of life, then the patient is eligible for hospice services. And we will just have to find other ways to sort of justify it. It went from having very specific criteria, say CHF having a certain ejection fraction, to us picking whatever is the closest or the most contributing thing to their decline. I have talked already about the difference between a terminal diagnosis, like in the old days, versus the all-encompassing terminal prognosis, as it is now. I mentioned the scrutiny of general inpatient level of care billing, which leads to the hospitals wanting patients to get flipped to hospice, which can be a problem for the hospice because often those patients are not really GIP eligible. Other things to know, in some places, hospices and nursing homes have great relationships. Not so much around here. Nursing homes, the nursing home business is a difficult business, and the nursing homes have established comfort care programs. And I've looked at the order sets for some of these comfort care programs, and it's really alarming to me because it ends up being a do not list. Do not resuscitate, do not intubate, do not give antibiotics, do not send back to the hospital. Whereas hospice is all the things that they get instead of those things that are on the do not list. And those nursing home patients are missing out on all those things. So palliative care, comfort care is not just a list of things we're not going to do. It's an active, involved process. And complementing this is the skilled benefit at the nursing home, the rehab benefit. So many of these patients who are in the last days, weeks, months of life, and who are eligible for hospice, who may desire a hospice plan of care, the families are forced to choose between, say, taking their loved one home, where the family would then become responsible for all the day in, day out care, and cleaning and feeding the patient and so forth. Or they could choose to go on rehab, and then they go to a nursing facility where all of their sort of personal care and meals and medications are all provided for them. But when the patient is on the Medicare rehab benefit, they can't be on the Medicare hospice benefit. And so these patients inevitably end up returning to the hospital, having their symptoms poorly controlled at the nursing home, and having a more complicated and uncomfortable death than was possible if they'd had appropriate hospice services. These are systemic problems that plague hospices everywhere, but it seems to be particularly acute around here. I mentioned the self-fulfilling prophecy, the notion that some providers think that hospice is really only for, or think subconsciously that hospice is only for the last days of life. And so when a patient gets referred in the last days or weeks of life and doesn't make their 3-month follow-up, that is then confirmed. Whereas if the patient were referred in the last when the prognosis is actually about 6 months, they could receive a lot more services, and also they could continue to maintain continuity with their providers if that's desired. And the lateness of referrals has really turned what we do into brink of death care. And we're good at brink of death care, but it's a real disservice to patients and to families, and it really makes it really hard on staff. Just to give you a sense of how late referrals are, the median length of stay nationally on hospice is 18 days, with 26% being on hospice less than 7 days and 50% being on hospice less than 30 days. But New York is 49th of the 50 states and territories in terms of hospice utilization, and with proximity to New York, it's particularly bad. And I can tell you that for us, our median length of stay is 12 days, and 42% of patients that we admit to hospice die within 7 days, and 76% die within 30 days. And just to be clear, we're not doing anything to hasten their deaths. Quite the contrary. It's that we are getting these patients referred to us so late in their course, after so many hospitalizations and so many second opinions, that it's really limiting the amount of time that we have to help the patient and family to really maximize their comfort and quality of life in their last days, weeks, months. As I wind up here, I just want to tell you some other hospice myths I'd like to help you dispel. We want patients to continue to see their doctors if they can after electing hospice. The doctors can't necessarily order 10 CAT scans and an MRI, but that continuity is something that we want to preserve. And we do try to we want doctors to continue to be involved in the care of their patients, regardless of even if I am doing the symptom management, which is most of their management, because that's my expertise. Hospice doesn't just crank up the morphine. Just about every patient is dispensed a small quantity of morphine as well as some other medications, for relief of emergency symptoms. In the case of morphine pain or breathlessness, the dose that we start at, 5 milligrams, is 1/3 of the smallest pill that's manufactured. So we are trying to use the smallest doses of comfort-focused meds that are necessary to relieve the symptom in question. We are definitely not trying to overload somebody with opioids or any other kind of medication. Another related point, we don't just sedate patients. Those who work with me here know how I rail against the use of benzodiazepines in the elderly and seriously ill. Try to avoid direct sedation. Try to avoid things that might alter the sensorium, which may not be able to be fixed, in the last days, weeks, months of life. And I guess the last point that I want to definitely make clear is that hospice does not hasten the end of life. In fact, appropriate palliative care has been shown to prolong life, to the extent that if palliative care were a new chemotherapy drug, we'd all be buying stock in the company. There are many more myths, but that's all I have time for on this slide and in this presentation. So I just want to say thank you for your time and your attention. And if you have any questions, comments, or concerns, I'd be happy to try to address them in the time that we have left.
Thank you, Dr. Chmielewski, for that really detailed talk on hospice. I know there's a lot of logistics to get through. We do have a few questions in the chat, and so I'll just start with, when you're introducing hospice, is there specific language that you're using with patients and their families?
That's a good question. I would say that the term hospice itself can be terrifying to patients and families and can be off-putting, but it's been studied that when you say hospice, it sends off all kinds of alarms. But if you describe the services that hospice provides, that can actually, everybody wants those things. Everybody wants more attention. A nurse visiting frequently. We have 2 full-time doctors And so we try to visit every patient who gets hospice with a home physician visit as well, plus social workers, plus. So I think that the idea of hospice being extra support for patients and families to help teach them and help them to care for their loved one, to help for the patient, him or herself, to maintain control of their symptoms, to maintain control over their life, to avoid things that are no longer helpful. I think those can all be good ways to sort of to think about things, to broach things for patients and families, rather than what we're doing now is going to stop and this entirely other thing is going to start. I think it can also be helpful. I feel, especially for me, practicing, out here in the burbs rather than an academic medical center. I think that, especially for patients who are coming from academic medical centers, think that maybe we don't know what we're talking about so much because there's something a little bit subversive about what we do in hospice, but subversive in a good way, in the sense that some of the things that are just like taken on faith, like for instance, for maybe getting a colonoscopy at age 50 or something like that. If somebody is, in the last days, weeks, months of life, then whatever their age, getting another colonoscopy is not something that is a wise decision. And that's a broad example, but it boils down to a lot of other little things about certain medications. So anything we can do in broaching hospice to help give us credibility and have and establish that we're all working together on the same team, that we all have the same goals. I get this all the time. Just because I'm a hospice doctor, I still want the same thing that every other doctor wants for patients. I want my patients to live as long as possible and feel as good as possible. And there's nothing that I would do that would compromise either of those two goals.
I guess somewhat in that vein, we have another question saying kind of what are your thoughts on the phrase withdrawal of care?
So I think that's a good question. It's a phrase that I would avoid. We're going to talk about withdrawal. We talk about withdrawal of artificial life support, withdrawal of interventions that are no longer helping and may now be harming. So I think we never stop caring. So we never really withdraw care. It's the power of language and words is something that's really of interest to me, and it can communicate so much more than we realize. And so when you say withdrawal of care, it can be taken quite literally as especially when there's a transition from, say, a hospital team or a clinic-based team to a home hospice team. It can feel like abandonment. We want to undermine the risk of abandonment. So talking about stopping things that are no longer beneficial, stopping things that may now be harmful, considering the benefits and burdens of every intervention. If we're going to use the term withdraw, then to withdraw artificial support, things like that. I think that's an easier way to chew on it for patients and families. And we're talking about the same thing. We're not trying to conceal anything. Like a similar example. I talk about palliative liberation from mechanical ventilation rather than terminal extubation.
Sounds terrifying.
Yes, especially since up to 15% of patients who are terminally extubated, to use a phrase I don't like, up to 15% of those patients survive their terminal extubation. So talk about getting your perspectives and your expectations all akimbo with that.
I guess somewhat, again, kind of in this vein of is there kind of specific language or how do you approach conversations with families surrounding IV fluids and artificial nutrition at home? I feel like that is oftentimes more emotionally charged.
Sure. And I think that the key thing to do is to remember I have these three guiding principles. One is that we try to let the patient's body guide us on this journey, let the body show us what it needs and what it doesn't need. And two is that whatever we do, we consider the benefits and burdens and only do things where the benefits clearly outweigh the burdens. Three is that we want to do whatever we can to protect the vulnerable from avoidable harms. So that comes into play with artificial nutrition and hydration in the sense that so we want to do what the body is asking for. And if somebody is whether it's artificial nutrition or careful hand feeding, that's something that when the patient is not hungry, and is not able to eat, that's the body saying, hey, I can't use that right now. That's not going to help me right now. And getting more food into that patient than the patient is asking for is not going to help them feel better, is not going to make them live longer. And getting less food into them, if that's all the body is asking for, even nothing at all, is not going to make them feel any worse, is not going to make them die any faster. With artificial hydration, it's really a question of benefits and burdens. In the last days, weeks, months of life, the burdens are increasing, the benefits are decreasing, and we shouldn't do things unless we are confident that the benefits exceed the burdens.
Thank you so much. I think we're just finishing our time, so I really appreciate you making the time.
Thank you very much.